My name is Derks. I am working as a metabolic pediatrician at the University Medical Center Groningen in the Netherlands. I am thankful to Danielle Dwagman for the kind invitation to present about prevention and acute treatment of ketotic hypoglycemia at this virtual conference. I don't have any competing interest for my presentations. On this slide you can find my transparency of interest statement, and for more information you are welcome at my professional website. It is important to mention that there are no formal guidelines on the diagnosis, monitoring and treatment of patients with ketotic hypoglycemia. In the medical literature, there is no consensus on outcome parameters either. Most knowledge is based on small cohort studies and expert opinions. In this presentation, I will mention elements of preventive treatment in ketotic hypoglycemia, such as the normal dietary treatment, and measures during anesthesia. I will also discuss acute treatment during illness. Depending on the severity of the phenotype, doctors and families decide what dietary management and monitoring is needed. Uncooked cornstarch can help the liver by providing extra complex carbohydrates that are broken down in a slow manner. Protein supplements can be added to prevent muscle breakdown. The dosing of these products and monitoring should be individualized and discussed between the medical team and the families. With this respect, as mentioned before, both over and under treatment can be harmful to young developing children. Different factors need to be taken into account, such as the severity of the symptoms and signs, the frequency of hypoglycemias, and the response to management. Fasting times are times before surgery when a patient is not allowed to eat or to drink. In case of a scheduled surgery, the fasting time should be known to prevent that food can be aspirated from the stomach. On the other hand, prolonged fasting may cause problems in patients with ketotic hypoglycemia. These are the general recommendations for children, and it applies to many ketotic hypoglycemia patients too. The risk remains that parents or doctors will try to choose the safe side and use or prescribe longer fasting times than needed. In any case, there is no clinical evidence for this policy. In any case, fasting times of 2 hours for clear liquids and 6 hours for non-clear liquids and solids are long enough. These fasting times are not so much minimum times, they are the times that should be adhered to. Fasting longer than the set times is not in the best interest of the child and is not recommended. In addition to the general measures, if possible, we recommend to schedule metabolic patients at the first place in the morning. Pediatricians should always supervise the hospital admission until food intake is guaranteed. Based on the individual fasting tolerance, extra measures should be prepared and carbohydrate intake and monitoring should be guaranteed during surgery by intravenous infusions. Acute hospital admissions are a big burden for many families taking care of children with chronic diseases. For patients with ultra-rare inherited metabolic diseases, information about disease-specific emergency protocols is available at multiple online resources. Examples include the New England Consortium of Metabolic Programs, the British Inherited Metabolic Diseases Group, INVEST, and the website www.emergencyprotocol.net. Scientific publications are available about several inherited metabolic diseases, such as the urea cycle defects, maple syrup urine disease, organic acidemias, fatty acid oxidation disorders, or incorporated in guidelines such as for glutaric aciduria type 1 and several subtypes of hepatic glycogen storage diseases. To prevent excessive breakdown of muscle protein and fatty acids from fat tissue, the key measure in many inborn errors of metabolism emergency protocols is the promotion of anabolism. In an international collaboration with the European Reference Network for Inherited Metabolic Diseases, in collaboration with many specialists worldwide, the website www.emergencyprotocol.net has been published. At this moment, using this website, emergency letters can be generated for patients with glycogen storage diseases and fatty acid oxidation disorders. The prevention of metabolic decompensation is also important in ketotic hypoglycemia patients. Metabolic decompensation can be characterized by hypoglycemia or hypoketosis and their corresponding symptoms and signs. Phase 1 of the treatment can be executed by families at home. Self-management and monitoring are fundamental for many families. Self-management is also important in emergency situations. When ketotic hypoglycemia patients become sick, for instance with fever and vomiting, the families usually need to take care of the first emergency measures starting at home. Many families use sugar-rich drinks or, for instance, carbohydrate gels. These measures are important because the oral rehydration solutions do not contain enough calories and carbohydrates for metabolic patients. Analgesics are advised for fever management. Phase 2 is executed in the emergency department or initial hospitalization, controlled by healthcare providers, before expert metabolic support can be sought. The emergency letter lists the ideal minimal laboratory tests required to assess the metabolic state of the patient in the first critical sample. For a patient with ketotic hypoglycemia, these tests could include blood glucose, a blood gas analysis, and bedside ketones. If oral food or formula feeds are not well tolerated, patients may need IV glucose at an appropriate rate to prevent further hypoglycemia or hypoketonemia. When patients need to be admitted to the hospital, the first healthcare professional in line is not always a metabolic expert or the endocrine expert. It is important that everybody feels comfortable and supported by good information and possibilities for good communication. Having an up-to-date emergency letter and knowing how to use it is important from a medical perspective and will optimize the communication between parents and doctors.